in these fields, the robotic surgery has some proven advantages. It was not the case for neurosurgery until very recently. As we know, some first attempt to make robotic neurosurgery have been made in the 80s of the last century, but for us, it didn't work well enough. For the last few years, we see a real boom, a real development rising of the application of robotic surgery in spinal surgery, mainly. And we see some new applications also in cranial surgery. So today we're going to talk with our good friend and the founding member of the EANS task force, Nico Sampron, who is from Spain, about robotics in neurosurgery. We will try to take a look in the future. We're not going to talk about technologies that are available nowadays, but we're going to talk more about the tomorrow of robotic surgery and how it will change our everyday practice as neurosurgeons. So I will not waste your time, and I will give the floor to Nico Sampron to present himself and to present also the topic. Before that, I would like you to check your Zoom window. You have a box with question and answers. If you have questions during the presentations of Nico Sampron, please send your questions there. We will try to answer them after the presentation. Thank you very much. Nico, the floor is yours.
Thank you very much, Nikolai, for your kind presentation. And I know that for our personal relationship, also for your academic work, that you are a very supporter of robotic surgery yourself. So I'm eager to know your last time experiences that you have, and how do you feel the future too? So I have to say and acknowledge that I have some conflict of interest regarding robotics. So you don't need to believe me everything I say. So, and robotics, as Nicolas said, is a controversial issue. And when I was thinking about how to prepare this lecture, I came across a tweet by the Elon Musk that states that robotic will surpass good human surgeons within a few years and the best human surgeon within 5 years. I think that this is a real optimistic view, and for sure our dear Elon is not very much acquainted with our European bureaucracy, because for those of you that are innovators and have tried to overcome not only the technical problems that are quite challenging, but also all the regulations and checks that are involved in this type of innovation in human surgery is really very time-consuming, very time-consuming. Anyways, I think that Elon was more thinking about the production of cars. If we see here on our left is a production line of a car factory 100 years ago, and to the right is same type of factories, but in current days. So you see the left image is I would say kind of resembles spine surgery today, while in the other you don't see humans. You don't see any human, and the cars are being successfully produced. But this image can be misleading, because if you zoom in, and take a closer look, you can really have a better judgment of the situation of what is called automation. For example, 100 years ago, the worldwide production of cars was about 4 million cars. Nowadays, it's about 88 million. That is a significant and exponential growth in the output of cars. And what about the jobs? What happened with the people working in those production lines? Well, the data is very clear. Automation not only increase the number of cars produced, but also increase the number of jobs and the individual salary of the workers. Also, there is a significant qualitative change in the type of jobs. While 100 years ago, it was the production line with physical work. Nowadays, if I'm not mistaken, I think that the number one job in the car industry is software engineers. But of course, you will say human beings and patients are not cars. And but it's important to know that automation does not just create or destroy jobs, but transform them. You know, having said that, and for that reason, that the patient are not cars, I propose to rethink spinal surgery from the beginning, from the first principle. And I think that we should divide the process of spinal surgery into 4 stations. 4 successive stations that they have a hierarchical order. And the first is the diagnostic. The diagnostics is important correlation between the disrupted anatomy of the patient and the patient problems, the patient suffering. Based on that, then we have a surgical plan. We follow up the patient. And we do that nowadays in 3 different frameworks that they usually live together in a regular modern OR of spinal surgery. And one is a freehand, the other is navigation, and finally, robotic assisted. And as I said, the most important of them is the accurate correlation between the structural anomalies in the patient and the suffering of the patient, the symptoms, the signs and symptoms. There used to be, or there was a very famous clinician that once stated that the technology that makes medicine progress the most was the chair. And he was referring to the chair that we used to sit down with the patient and to talk about their complaints. If this step fails, it doesn't exist or not will exist any technology in the OR that can compensate for a mistake made in the diagnosis. Then we have the surgical plan, which the most important tools is for sure the human brain, your imagination, your knowledge about the anatomy, that shouldn't be underestimated. The human spine is probably one of the most complex structure in the human body. It is at the same time is solid and elastic, and it's really different from one patient to the next, mainly due to the variability in anatomy, but also the effects of the degeneration in the spine. Then we have used the classic technology, which is a pen and paper that we used to do. And nowadays we have amazing planning station. For example, I have a screen capture of the Brain Lab software. And but the important thing here is once more judgment. Now technology will replace or will make it for a poor judgment. And you usually, and this is a principle in our setting, always choose the easiest and least invasive, very importantly, among the effective alternative. Execution is the scenery for robotics to play, and it's the actual surgery. And it is an interplay into three elements: sensor, effectors, and tool. And once more, we have different types of sensors available. We have our vision usually augmented by loops or by machine to see through the skin, for example, 2D CRs or 3D devices. We, very important, also use the tactile feedback and also acoustic, because when we are doing freehand surgery, even if we are not conscious, we guide ourselves with the different sound of tissues and of the tools when they interact with tissue. For example, hammer and chisel, classically, there is a different sound for the different elements that encounters, but also, for example, the high-speed drill, how it's on with when there is or not soft tissue. Also, our machines like navigation or navigators and robots, they need to sense the anatomy of the patient, and they do that usually by the so-called optical tracking, which is the widespread technique that nowadays we use in navigation and robotics. But there are others, and I will briefly talk about a system, tracking system that I was collaborating to build that as an innovation. The effectors, there are only two kinds: our dear two hands and robotic arms. But the question is, what's better, human hands or robotic hands? And it's a misleading question, because you should ask, better for what? Better for what? For sure, human hands are very versatile. The same hand that is used to do final surgery is also used for other things of everyday life, like doing the button of your shirt, tidying the lace of your shoes, combing your hair, except in the case of Nikolai. I'm sorry for the joke. That human hands, very versatile. But for specific functions, such as those, and I think that Nikolai will agree here, those that we need in spine surgery, human hands are not so good or so reliable. If I ask you to hold something in a weird position, you will resist well a couple of minutes, but after 10 minutes, you will be suffering and probably failing. We took this picture today in our OR, and you see that the human hands here are really struggling to hold tight, a given trajectory. Two hands and really suffering for the instrument not to escape, in this case, the entry point for a pedicular screw. So better human hands or robots? Depends. All depends on why we need them for. And tools, we have to think that tools will be rethought probably in the next year, because all the tools are sought or are developed for human hands. And now we start needing tools for robotic hands and arms. So together with the innovation in sensors and in effectors, there is also need innovation in tools. And of course, the way to progress is to uncover mistakes in the way we do it currently. And the only way to discover those mistakes, the only way to progress is to follow up our patient and to follow up our processes, and to have an self-critical mindset. That is very important. If we go to the fact, we see that if we take a look on pedicular screw, the really big leap in the last decade is due to navigation. It's really important and very significant how the rate of misplacement of pedicular screws with the incorporation of navigation dramatically dropped from 20% in the free hands, and those are rough number of my estimation, to 2% in the navigation group. And you can say, for those of you that are developers of robotic spine surgery for screw placement, how can you justify all this effort if it's only for pedicle screw, when you already have a technology that provides 98% accuracy? It's really difficult to justify it only for this. Well, supporters came with this criticism, which is, okay, with navigation, 98% of the screws are within the pedicle. However, there is a significant mismatch if we compare the trajectory planned and the trajectory really achieved. And this, although it's doubtful if it is clinically relevant, may signify an advantage for robotic surgery. Robots are actually more precise than a conventional navigation. This is a typical case of robotic, where you have the not only the implant right exactly in the pedicle, but almost perfectly in the planned trajectory. And it's not surprising that both techniques are achieving this result, because they are based basically on the same. Is this optic tracking with reference put to the spine of or the iliac crest of the patient, and another reference in the tool. The robot is basically the same, but with the addition of, as I say, strong and reliable robotic arm. And all of the available robots in the market are based in this optic tracking technique. The problem, and this is the problem I want to conclude with, is the scalability of this tracking technology beyond the trajectory finding and holding function. Because if we step forward and we think about bony removal and robotic laminectomy, we need more accuracy, more reliability, and less inconvenience derived from the optic tracking, such as the dependence from the distance of the reference to the camera, the possibility of obstructions in our way, also the computing speed, because you have to think that the optic tracking, what it's doing is taking a lot of pictures of is about 200 pictures per second and processes all that huge amount of information. And there is also the problem of uncoupled displacement between the place we are working in, the vertebra we are working in, and the place where is attached the reference. But could we do without optical tracking? And the answer is yes. I was lucky enough to collaborate with a group of engineers that were developing this innovative so-called kinematic tracking, which is so simple that the first time that you see it's impossible that this thing had not been invented before. And it's a simple passive arm that is attached to the same vertebra ideally that you are working in. And it has 3 joints. Inside the joints, there is a very precise devices that measure the position of the joint. And with that information, which are 3 numbers, only 3 numbers, not images, they can provide you in a very precise way to the order, a precision of the order of 0.1 millimeters is a 10x increase in precision regarding the optical tracking, and all that with less computing. So we have an important simplification together with precision. I show you a video. This is an early prototype of the machine in the cadaver lab, and you see the passive arm attached to the spine, and then the active part of the instrument that you use to guide your trajectory. As you see, if you move the patient or something moves, the robot immediately responds to the movement and can follow, for example, the breathing motion on anything that is moved, the robot will follow. And although this might not be especially relevant for pedicles replacement, we think that could be game changer for the next step, which is robotic laminectomy. Robotic laminectomy is very incipient. Some surgeons are being used the currently available robot to establish trajectory along the lamina, and in that way assist in robotic laminectomy. This is an example. Other authors have been using the endoscope through the robot, so using endoscopic and robotic assisted laminectomy. And there are other developments. For example, this coming from China is a classic midline approach with a robot based also in optic tracking that is using an ultrasound cutter to perform a classical laminectomy. This is very interesting. It's a robot that has two functions, also based on optical tracking, and is helping the surgeon to define the limits of a laminectomy, and also has an autonomous function. We will see. And this is our prototype, which is in this function is completely autonomous and is ultra precise. As I told you, is the precision in ideal condition is of the order of the 0.1 millimeters, and it can perform, for example, one level over the top decompression in a lapse of time of about the order of 1 or 2 minutes. It's very impressive, and I say that in the future, as you see, is what I'm showing you was at the stage of Phantom, but will probably be a protagonist in the near future. So to conclude, I want to say that from first principles and rethinking the whole spinal surgery, we can derive the place of robotics in spinal surgery. And we have reminded that the giant leap in accuracy is due of the last year is due to navigation. And current robotic, I think that it's fair to say that there is a marginal advantage. I think that the next step is robotic laminectomy, and the future of robotics is anyway promising. Thank you very much. Thank you.
Thank you very much, Professor Sampro, for this really marvelous talk, starting from what we can do with our hands to what robots can do now and what we can hopefully expect them to do in the future. Now it starts the discussion section of the webinar, and we have first Nicola Gabrowski with a short comment, and then we'll take your questions. So please don't be shy and write them in the Q&A section.
Thank you, Alessandro. Thank you, Nikos. It was a very interesting overview of what's going on in robotic surgery. I was impressed also with the beginning of your presentation. There is a philosophical problem with all this advancement in AI and robotics. Shall we need physicians in, let's say, 10 or 20 years to come? I would like to share with you that recently I saw a very interesting presentation for a very prominent visionary and futurist. So he presented very well the numbers, especially regarding AI. This is a real explosion of the capabilities of AI, including in medicine. So regarding the enormous investment that the most powerful companies are having in AI, his view was that very soon AI will be better than us in programming, and that's true. There are some competitions in programming where AI has been in the first 10,000 as a result on the programming competitions, and nowadays he's in the first 100. So things are changing quite fast. From this point of view, he said that he will become so good in the next few years that almost all disease will become curable, because AI will find new ways to treat patients, will find new antibiotics, and we already have some examples about this. AI will control the genetical and epigenetical epigenome better than us. So very soon we will not need physicians, because almost all diseases will be treatable. Of course, I think that this was very, very, very optimistic from his point of view. And this was proven also by a colleague of us who is a prominent neuro-oncologist, who after the presentation says, I have spent 40 years in studying glioblastoma. We made a huge, enormous advancement in every single aspect of the knowledge about this tumor, but the results that we have for the treatment of the tumor are really not encouraging, despite all the advancement in genetics, epigenetics, AI, etc. So we have to be very careful when we make prognosis. Of course, we should be optimistic, but I think that still the illusion that things will be very easy and will change very easily, and we will resolve all the problems that we have in medicine and healthcare thanks to AI or robots. I think that this is some kind of naive. Of course, our profession will change a lot. Of course, the way we treat our patients will change a lot. Our possibilities will change a lot, but this will not. This will take some time, first of all, and we will come, I think, more or less step by step. So I'm talking about this because I think that we should remain optimistic. Medicine and healthcare will need physicians in the close future, despite that will completely change the way we work. Of course, I think that this is more an opportunity for all of us. When we talk about robotics, we should always talk about AI because we see a big development in the field of robotics, but one of the leading things of the development of robots is AI. So I think that these two fields are not separate at all and should be discussed as a whole, as a complete, as a complementary one to each to other. So I think that robots will not surpass us soon. I think that we will become better in our job thanks to them. We will be able to obtain better results thanks to the robots. We will be able to obtain better results faster because, let's say, putting a pedicle screws needed a few years, 5 or 7 or 10 years of experience. And now even someone that is in the beginning of his career can, thanks to these technologies, put a screw following the correct trajectory. So finally, I think that all the shortage that we have in the field of healthcare could be covered by these innovations. And finally, in a few years, the results will be that we're gonna treat our patients faster, better, and we will have much more options. So I'm really optimistic, and thank you for this overview about robotics, because I'm sure that spinal surgery will completely change in the few years to come thanks to this technology. You mentioned, if I can ask a question at the end of this short statement, you mentioned decompression. What do you think is the main burden? Why we don't have still a reliable decompressive tool, a robotic tool? Why? What is the challenge? What is the problem?
For me, there are many challenges. One, not to be dismissed, is the bureaucracy, which in Europe is becoming a nightmare, and many innovators are aware of that. But if we go to the most interested challenges, which are the technical, first we have to think that the precision that we are talking about, if you compare with defining a trajectory with pedicle screw, is several folds more. So you need a very precise and reliable bone cutter. And the development is, I think, is the key are, as I said, the tracking system that can be. I'm not saying that the optic tracking is not able to do it, but it will need to be combined with some other precision tracking on the one side. And also, the tracking can be multimodal. They are not. They can be used in combination. And on the other hand, you have the tools. For example, there are physical tools like the high-speed drill. They are ultrasonic bone cutters, and they are even laser development to cut bones, at least in in research. And I think that, as far as I know, there need to be a merge between companies developing robots and companies developing bone cutting devices. And this merge is essential to provide a reliable thing. I think that as we start seeing in the literature, robots are already useful. If you like to design or cut or make a rough cut to begin with, and to set the limits of your decompression, for example, of your osteotomy or your facetectomy for a TLIF operation. And I think that is coming probably soon. But what we are working and we would like to see is a really full autonomous, rapid, reliable laminectomy. If you can offer a device that can perform and not only the trajectories for the implants to be placed, but also very quick bone removal, even if you are not removing, for example, the yellow ligament or the more delicate part, you think that you can not only improve results, efficiency in the operations, both everyday simple one-level decompression and complex osteotomy or oncological spine surgery. I was saying that this is probably big progress in spine surgery. And of course, I'm not that optimistic about AI regarding the most important, as I said, hierarchical stages of the surgical process, which are the judgment with the patient, sitting that with the patient and decide what to do, and also to decide among all the options, because it's easy for AI to answer something where there is a kind of uniformity, many data points that are related between themselves, but where it's a unique situation, like every patient is more difficult for AI. I think AI will be helpful, and we are working on that too, for helping us to plan and to propose as solutions, that not to, by any way, to have a role in decision making.
Thank you for this very deep discussion about from the philosophical point of view to the technical one. We have one first question from the audience, which is, you were talking about potential inaccuracies of the tracking system, but often the registration error is larger than the tracking error. How can this be overcome for bone work? So with regards to laminectomy, not only regarding the trajectory for screw placement.
Yeah, that is absolutely right. The registration process is a key when you want to go to a really precise surgery. And of course, the technology for registration is variable. And but what we think that you need to do is to have first the reference put in the same, ideally in the same vertebra that you are working on, if you want a high precision. And the next is to use 3D imaging acquisition devices which are a lot of precision, and also the imaging technique. The imaging technique is also can be also a source of error when we are talking about this sub-millimetrical type of error. The quality of the imaging acquisition device becomes relevant. So there are many things to do.
So the precision level could change from 3D fluoroscopy to arms to a CT scan intraoperatively.
Exactly. For example, if you have a CT which is the quality like those that we use for diagnostics, that precision is significantly higher than the 3D devices that we used to have in the OR, and more so, of course, the 2D. The 2D.
Absolutely. Okay, while we wait for more questions from the audience, we have Professor Ivanov. They have a couple of comments. Please, Professor Ivanov, floor is yours.
Oh, thank you so much. Thank you. First of all, Nico, congratulations for very didactic and very thoughtful presentation. I think it is really important to understand how things evolve and how this progressed, and what is more important, what are the challenges and what are the expectations. And I must say I'm really excited that we live in this time, because I think we are really privileged to live in this time of revolution, not just in medicine, but in kind of century when the time, similar to the time when the internet appeared. Now this artificial intelligence and robotics make a really big difference to what is happening around. There is this huge fusion between precision, sub-millimetrical precision of the robots and the power of AI, which we could only dream of or read only in science fiction journals just a decade ago. Now, when we talk about robots, I think what is important to understand is that we have some expectation from the robots. Yeah, we want these robots to be able to do some of our activities, to replace some of the difficult tasks with at least the same accuracy, probably better accuracy, with the same safety, and to allow us to do something else instead. So this is now very well implemented in many fields. Yeah, you very nicely showed that the cars are now built predominantly by the robots. We can see it in our routine life. We have robotic hoovers. We have a robot preparing a pizza for us. In spine surgery, we are still not there. Yes, but we are at the beginning. I think we live in this exciting time of beginning of robotic surgery, which will rapidly evolve over the next few years. So what we have now, at this stage, we have a robotized arm which has sub-millimetric precision to bring the instruments and hold this instrument in a trajectory which we predefined in advance. And what we really want to do is the robot to be able to do something for us with the same precision, not just to hold the instruments, which is happening already, but to be able to do part of the surgery by the robot with the same safety. And this is where the impediment is. And this is why I'm really excited to see that in your presentation, we had this part of the surgery, for example, laminectomy, is done by robots. So it is similar to 3D printing, but in a reverse way. Instead of printing something, the robot can very accurately remove a predefined volume in very accurate way. And this is why I think what makes the difference, and this is what will make a difference between holder of the instruments and an active robot. Now, all the promoters of the robots, they really say that, look, it is increasing the precision, timing, safety, but this is all if we compare to freehand surgery. If you compare to navigation only, there is not such a huge difference, but you are absolutely right. The robots doesn't have this fatigue. Yeah, so the robots, they can do the same process with the same accuracy, which is unlike humans. They don't get tired of this. And once we see robots doing some parts of the surgery with the same accuracy, I think this is when the revolution will really happen in terms of what we do and how much we achieve with this kind of surgery. So thank you very much. Just wanted to thank for this very nice topic and presentation. Thank you. Thank you, Nico.
Professor Sampron, you want to comment on that, or we'll go to the next question?
No, I think we have discussed a lot of. You also made me think our great friend Andre that sadly passed recently, and I was a little bit moved because he was. We are talking about Professor Maciejek from Poland, and he was a great enthusiast of robotics. I was having very interesting discussion with you, Marcel, and he said that after, I don't know, probably more than 40 years experience in spine surgery, he was using the robot every day, and he thought that it has advantages. Particularly, the more complex or the longer, the more level, the vertebral level the surgery includes, the more the benefit he encountered in the current robotics. Because when you have a big construct, you like to plan very well in advance, for example, to make match every entry point. So in a moment that at the moment when you have to place for example, a preformed rod for a deformity, you are making everything come together with great precision, and this is true with the everyday struggle in complex spinal surgeries to make the final adjustment to the complex construct without stressing the pedicles, without pulling out pedicle, taking the most of the purchase in a vertebra that might have weak and strong points. So Andre saw a lot of advantages, and I think that and we can share that. But also to recognize that the giant leap that represented navigation more than robotic.
And just to add to this, I think what we really need to take it to see it as not as a replacement of our surgical skills or mental kind of abilities. It should be an option which should augment our abilities to do things safer, more accurately, equally with navigation, and now with robotics, which doesn't have this fatigue and have this ability to do these repetitive movements with high accuracy. So it's augmentation to what we normally do, and we should really embrace it and explore. That is the first step for everything. So I think we are making the first steps, but I really believe that it will rapidly evolve in the next few years. So good to be part of this.
Thank you. So we have time for a last question, which is going to be about haptics. So what do you think haptics is going to be part of this robotic revolution in some way? As for now, robotics is more related to a set of coordinates to be followed, but there's nothing really related to be able to touch, which is still a very important thing in our work as human surgeons.
Yes, as I said, with the first principles analysis, tactile feedback is basic in all surgery. And but when we talk about haptics, there are two things. One is a certain feedback that a tool provides over the surgeon. Now, for example, having an assistant robot that will have a reaction to the density of the tissue is passing through. And another thing that could be haptic is what I show, and I was calling kinematic, is the way, a different way of tracking, which is this passive arm attached to the vertebra and detecting not only the position, of the anatomy, but also the movement. Any minimal movement of the anatomy is detected by this so-called haptic, kinematic, whatever. And I think that the future, there is a big discussion. My position is that I see robotics more like autonomous, that when the surgeon is doing the planning, like similar to what radio surgeons do, you draw your the bone that needs to be removed, and then the robot will do it for you. And in that case, the haptic does not apply in the first sense that I was talking, that the feedback that a tool can provide to your hands. But the other haptic is the robotic haptic, the kinematic sensoring of the position and the movement of the anatomy.
Okay, thank you. We have one really last question from the audience, which I'm going to summarize, just asking if your discussion with the patient changes if based on the technology you're using in the OR, so navigation, robotics, or not. And then we're going to go to the web.
Yeah, absolutely, because the significant, the important technology, not the irrelevant technology that there also are, but changes the profile of risk of the surgery. If you are saying that a certain technology such as navigation make the surgery safer, this should also in some way modify the balance risk-benefit that you discuss with the patient. For example, in the past, I don't know, 20 years ago, if you were a 80-something years old patient, you won't receive a simple lumbar decompression for spinal stenosis. Nowadays, thanks to the dropping in the risk of everything related to surgery, that's everyday surgery, at least in Europe when we have a old population.
Okay. Thank you very much. It was really an interesting webinar and discussion, and I'm going to leave the last word for Nicola Gabrowski. The floor is yours. You are muted.
Thank you very much, Alessandro, for this very interesting discussion. Thank you, Nikos, for this presentation. Definitely, this is a burning topic. At the end, I would like to thank all the participants and to remind you that to the European Congress of Neurosurgery that will be held in Vienna from October 5th to October 9th. There will be NT sessions where we will have more time to discuss all these problems. And as far as I see, there will be new things that will appear for this short period. Just for your information, the early registration for the European Congress of Neurosurgery in Vienna, the early registration is until the 15th of June. So it's better to do it in the month to come than later. Thank you very much for your participation, and I hope to see you to the next EANS webinar and to the next 18 webinar. Bye, guys. Bye, ladies and gentlemen. Bye, dear friends.